CSI, NIC to giving me this opportunity to be here and to share this case. I'm currently working as a senior consult cardiologist in the Chagan Heart Foundation in Chennai. Most of my intervention and child training was in UK, in Cardiff and Manchester and Liverpool. Now this case, it's very specific for India as well as Asia, having a smaller valves. We have a lot of bioprosthetic valves which are 19 millimeters, which are failing. And when you go for a valve-in-valve for these patients, what matters is the inner diameter, the true diameter, which is around 16.5. And if you put a valve-in-valve inside that, you will end up with a 15.5. And most of my colleagues who are doing a lot of dialysis, they will understand that. You have a problem with a very small orifice, high gradient, and more symptoms. So what is the solution and what can we do? So that's what this case is about. So a 61-year-old gentleman, type 2 diabetic hypertension, CKD, the usual sort of phenotype. He had an aortic valve replacement done with a 19 millimeter perimount valve with coronary bypass surgery in 2006. He also has restrictive lung disease, severe glaucoma with loss of vision in one eye, and recurrent hematuria as well. That's one of the reasons the anticoagulation was not considered, and he was having a bioprosthetic valve when he was in his late 50s. 3 months history of worsening dyspnea, and he had an echocardiogram done locally. He's from Bangalore. And the peak gradients were 100, mean gradient was 65, valve area was 0.5 to 0.6. So a lot of options were discussed in Bangalore as well as in a couple of hospitals in Chennai, other places. All of them considered redo surgery was high risk. And he was assessed in our hospital. STS was more than 5, so he was moderately high risk. After a hot team discussion, we decided that we will consider him for a 23 millimeter evolute valve. And I will go through why the decision was made and what is the advantage of having a supraannular valve compared to an intraannular valve in these small bioprosthetic valves which are failing. So this shows the inner true diameter, which is 14 by 16, and also the stent post of the previously failed bioprosthetic valve. Now this one shows the Itali assessment, and the perimeter is 50, very small. And also the other thing is the sinus, which is around 20 to 24, 23. So these things you need to keep in mind before you select your valves, and also the coronary height. And this is what I was talking about. So a bioprosthetic valve, you have a stent, inside that you have the valve, and the true inner diameter is what matters. And if you put a valve inside that, which will be giving around sort of 14, 15 millimeters, your effective orifice area will be low, and your pressure gradient will be very high. And this is the advantage of a supraannular valve. So the evolute rod opens up about higher than the sort of native annulus, it's called supraannular. And because of that, it gives a more effective orifice area and a lower gradient, especially in a small valve. You can see here, if the valve is less than 20, the gradients with the intraannular sapien valve is up to 40. And the supraannular core valve is around 20-24. So this is the advantage of putting a supraannular valve. The other option, if your center is purely going for intraannular Edwards valve, is to do bioprosthetic valve fracture. So you fracture that valve with a very high pressure balloon and then put a valve. But that has its own downside and disadvantage. So after this, it was the decision making was the important aspect in this case. After that, once you decided, the procedure was any other sort of evolute case simplified. So contralateral injection, checking the femorals, the facing wire was in place, Amplex one was used, AL1 used, and crossed with a wire, and the exchange for a super stiff wire, and then fluoroscopies to check the valve if it is loaded properly. The other thing I noticed, especially in our population, is this acute bend in the aorta. You have to pay extra attention when you're taking the valve through that, and help with the assistance sort of pulling the wire slightly. With this case, the other issue we had was getting this valve across this stent. It was a slightly right angle, so it was hitting the stent post most of the time. So the technique was the assistant was pulling the wire, and then we managed to get it in. If it didn't work, the other option would have been to change it to a much stiffer wire, Lundakus wire, and that would have taken it. So the valve was placed about 3 to 5 meters depth, 2/3 deployed, and the coronaries were checked. And there was good coronary flow, there was no obstruction, and there was no AR. So the valve was fully deployed. It was a nice symmetrical deployment. And the next view will show that there is no AR at all, literally no AR. Very satisfied, and coronaries were patent. And the gradient was, mean was around 10, maximum was 20. This was immediate post. And at 1 month follow, the gradient is now around 25, and the mean is 15. And 3 months follow, it's staying the same, around 15. And that's what we see. There will be slightly raised, about 10 millimeters at 1 month to 3 months, but that seems to be staying. So the take-home message is, we do have an inherent problem of small aortic annulus in the Asian and Southeast Asian population. We will come across cases with small upset of bioprosthetic valves which are failing. It is important to know the type of valve that is put in, whether it's stented or stentless, the leaflet position, like the mitral flow, where it might open into the coronaries, and also selection of the TAVI processes, depending on your center's expertise. Supraannular is a very simple procedure with the evolutor, but if you are used to an Edwards intraannular, then you have to go for the bioprosthetic valve fracture. And you will get a good effective orifice area and a low gradient. Now this has to be looked at in long-term follow-up to see how much it affects the mortality and morbidity. Thank you. Thank you.
How exactly you decide the supravalvular position for that? No. How exactly do you decide where to position the valve in this case?
Now the positioning of the valve, the evolute is 3 to 5 millimeters depth. So the cell, the lower cell is where the lower part, upper part, and that band from the lowermost to the first band is about 6 millimeters. So if you are just below that, it will be 5 millimeters. So that's what we are aiming for, about 3 to 5 millimeters.
Okay. Thank you. We will request Dr. Raman Chawla to present the next case.
Good afternoon, all of you. My case is relatively simple. A 55-year-old male non-diabetic, non-hypertensive had injured for the last 5 days. ECG shows V2 to V4 T inversion. Troponin I was positive. EFS is reasonably good. We started with angio, which showed that he had significant lesion in LAD. We wanted to intervene for PCS LAD. Right atrial vesicle, EBU guide was there, and I just measured the lesion with a radiopic part of the wire. Wire was crossed, and just wanted to did pre-dilatation, and after pre-dilatation, 3 into 39 millimeter stent was positioned. So the position well dilated, graded the balloon. This was positioned just to see that left main. I'm not impinging into left main. LCX was small and distally already occluded. RC was large and dominant. Balloon deflated well, but while trying to pull out the balloon, shaft broke. Balloon stuck in left main and LAD. You can see that partly balloon has come out, as in left main and LAD. Physical operation was fine, but suddenly, actually, patient started complaining of pain. By the time this happened, the wire came out. You see this previous wire, with the first wire came out and then recrossed. You see something is funny here. Wire came out, recrossed with wire. The wire has gone into broken lumen. You see wire had changed. See this wire, different wire. Came everything out, wire also came out, recrossed and the wire was changed. Now this is different wire which by chance went into the broken shaft of the balloon. Right, this is what I observed. Tried to, while wire came out along with the balloon, partly balloon came into guide. Now we had a balloon hanging into left main, LED, guide and wire exchanged on broken shaft, which was by chance. I thought I'll try with twisting wire technique, which actually failed. I was trying to twist a wire, even if I don't enter into coronary, which I was unable actually, I thought I'll twist into guide itself. Patient developed cardiac arrest, cardiac massage started. This is cardiac massage going on. And then I realized that as part of the balloon, and obviously the broken shaft has to be in the guide because most of the time the balloon gets snaps off at the hinge point of rapid exchange wire. So I inflated a balloon in the guide, trapped this broken balloon into the guide while massage was going on and pulled everything out. So I engaged the guide to see that the LED was flowing, patient stabilized again. This was another shot just to see everything was fine, well posted. Patient was discharged, stable, shifted to ICU, discharged after 2 days. I got a call again after about 2 days of discharge that patient complained of difficulty in breathing. Attendant was advised to bring the patient to hospital. Patient arrived after 3 hours and patient was brought dead on arrival. I thought where I went wrong. I reviewed the procedure. If you see it carefully now, you see something is wrong at the proximal part of the stent. Actually, stent got crumpled while it might have been happened while I was trying to put the balloon out. The guide must have got deep into LED. The stent was positioned at the ostial part of LED. Now you can see it is at least a couple of millimeters away from ostium, and see the proximal part of the stent is crumpled. You see here also, you can see something negative shadow at the distal part of the crumpled stent, that is proximal stent, distal part of the crumpled stent. Some haziness, some slow filling. So possibility of thrombus because of crumpled stent and other things. So I conclude by saying that once you have come out of problem, please do not forget to review the case again, that where you went wrong, why you went wrong, is anything left behind, and next time don't do the things again. Even if we know that if balloon is stuck up, we know the ways. You push the balloon slightly before taking it out, you rotate it slightly before taking it out. You can use other things also, but even if you know it, once you have problem, you don't think that much. The idea is, once you have problem, you come out, please review the things again. You must know all the technique. You don't know which technique is going to work in what patient and how you act quickly in this patient. Thank you for your patience, Eric. Thank you.
There is some longitudinal shortening. There is some longitudinal shortening of the stent. The original is 40 and at the end it looks as if it is about 30 or so. The proximal part, in fact, looks more radio opaque than the distal 80% of the stent, proximal 20%. So
this is what I told you that actually stent got crumpled, it got longitudinally compressed. You can see that proximal part of the stent was looking much more radio opaque. Once I reviewed the CD again, after patient was brought dead, then I realized that that part was because of guiding must have gone into the stent at the time, and probably there was some radiolucency at that area also at the end of the procedure, which I missed. So missed 2 points, crumpled stent, radiolucency. It was only once patient comes out of problem, you start feeling happy and you don't review what has happened wrong.
Actually, this type of break in the balloon shaft commonly occurs whenever you use old ends figure 3.54 post dilatation. So if you don't adequately deflate when you pull, most of the time it will start at the catheter tip and the balloon shaft. Recently, we were doing one primary PCS. It was not a left main start because the post dilatation, when it starts, then balloon trapping, deeply engage the guide catheter, half balloon into the guide catheter up, then we pulled it out. Ultimately, the patient was safe, but nicely done.
Okay, thank you.
Thank you.
Next, Dr. Varsha Kiran, transeptal ascending aortic axis, facilitated coil embellishment of type 1 endoleak, following a penetrated TAVR.
I think the wrong one is
Number 3 was
this is another case. What's your
okay.
So Varsha, there are two of my cases. This is the second one that appears.
Okay, no issue. You can present that one.
I can present that.
Okay, two are there.
Okay, 1 second. You want to present acute ischemic stroke?
No, so this endovascular repair in octopus section.
Endovascular aneurysm repair, octopus. Yeah, this is what it is.
So good afternoon, everyone. This is a challenging endovascular aneurysm repair from our institution where we repaired it using an octopus technique. This is the story of a 61-year-old lady who had come with low limb claudication for 2 years with a recent worsening of symptoms. Claudication distance at presentation was only 50 meters. She was a hypertensive for 15 years and at presentation she had absent bilateral femoral pulses. This is the initial CT angiogram. As you can see, there is a Crawford eccentric thoracoabdominal aneurysm arising from the mid-thoracic renal level with extensive wall calcification. And the largest dimension, as you can see here, is around 8.5 centimeters. It suggests imminent rupture at any time. Another notable feature is severe circumferential wall thickening of bilateral iliacs with stenosis. That makes a really significant impact in the access site and management. After that, this is a 3D reconstruction image of the same. Subtle finding is basically a large collateral coming from the SMA draining into the IMA, which probably suggests there is a high-grade intrarenal aortic stenosis bar occlusion on the long term. So this is a cross-section image which actually shows an underlying high-grade calcific stenosis over which there is a superadded thrombus, which could explain the cause for recent worsening in symptoms. So what are the options we considered at this time? We did consider a surgical repair, but then looking at the iliacs, looking at the circumferential wall calcification, even on the aortic aneurysm, no surgeon would be happy to touch this patient. So that makes surgical repair or a hybrid repair non-viable. So we did consider an endovascular option. We considered a fenestrated or a branch kind of repair using a custom-made fenestration or an on-table modified device or a sandwich technique. But all three techniques require a really large sheath devices up to 22 to 24 French. And with this severely diseased iliac, even an iliac conduit is not an option. So that is why we look for the 11th amazing fact about the octopus. That's the octopus technique. So this is a representation of various types of aneurysm repairs. I'll just stick to the octopus technique. This is how an octopus endograph looks on table. So this is a regular bifurcated device with a main body, a short contralum and a long main body extension. So through the short contralum, we could easily access 3 of the visceral arteries and put a branch covered stent graft. And the main body, we should take care of the 4th visceral artery using either a fenestration or a sandwich technique. So there are many advantages of this technique, the most important of which is individual customization is not necessary. And the graft limb orientation to visceral vessels is not necessary to get good flow. And axillary access provides simplified visceral cannulation from the contralum. And branch graft flexibility is better tolerated and graft migration would not cause a stenosis or occlusion. And we also, this gives us a good more than 3 centimeter limb overlap, ensuring adequate and durable seal. We were left with a lot of challenges in this patient. The first one being an intrarenal aortic occlusion and severely calcific iliacs, which not only makes her a poor surgical candidate, but also make tracking any endograft very difficult. And the other big challenge left with us was to maintain the flow in the 4 big visceral arteries, the celiac, SMA and bilateral veins. So this is our first challenge. This is an initial angiogram done from the left radial route using a pigtail catheter, which shows an occlusion just below the left renal artery, aortic occlusion just below the renal artery. And right renal artery, as you see, is heavily calcified and stenosed in the proximal segment. So on day 1, we just put a 5F GR catheter from the left radial axis, stabilize the catheter using the stiff end of a thermoglide wire, and thrombolize her overnight using 2.5 lakhs urokinase per hour. And remarkably, next day, the femoral pulses were palpable. So we were able to take a bilateral femoral axis and using a Linderquist wire and a Watt catheter over it, we carried on the subsequent angiograms. So the thrombus had cleared up, leaving just the calcific plaque in the intrarenal aortic region. And the panel on the right shows the upper extent of the aneurysm. So remember, we had severe circumferential wall calcification in the iliacs bilaterally. So to make sure any endograph would track through it, we had to prepare adequate bed. So we started off with stenting both common iliacs simultaneously using an 8mm balloon expandable stent. And subsequent post-dilatation was done with a 10mm balloon on the right side and 8mm balloon on the left side. This is to ensure that the right side was big enough to enable the tracking of an endograph. After that, we took an endurant bifurcated endograph and deployed it, fluoroscopically marking the upper extent of the aneurysm to achieve adequate seal proximally. And as you can see, this is the wall of the aneurysm with calcification. We ended well above the aneurysm segment. And the other important thing is we may ensure that the short limb is facing anteriorly. This is to ease the cannulation of visceral branches. So the next step, from the axillary 14F axis, we got into each of the branches, the celiac artery, right renal and the SMA, through the contralimb of the bifurcated device. We got in with a JR and taken in using a thermoglide wire, which was exchanged to an NIC wire. Subsequently, all 3 branches were stented using covered stents, and these stents were proximally extended such that all proximal extension ended at the flow splitter of the bifurcated device. Then we had to extend the endurant main body to the intrarenal aorta, and at the same time we had to do a periscope stenting of the left renal artery to maintain flow into the same. So at this time we had to ensure that the lower end of the periscope stent to the left renal artery ended below the endurant main body to maintain flow into the renals. So these are the final angiograms after stenting. As you can see, there is a good exclusion of the aneurysm sac with a faint type 4 endoleak, which was due to the graft porosity, which is likely to settle over time. And there is also preservation of flow into all the branches. And this is a picture of the terminal aorta with no gradient between the ascending aorta and both femorals. There is a small dissection in the terminal aorta, but was non-flow limiting and it was not intervened upon. This is a pictorial representation. The panels on top are the pre-intervention ones, and the panel below is the completion angiogram, as you can see. This patient has come back for a follow-up after 4 months, at which time her claudication distance significantly improved and she was able to walk a kilometer. And the panels on top show the cross-section CT imaging showing good thrombosis of the aneurysm sac and filling of the main body of the bifurcated device. And you could see like a Mercedes-Benz sign. The 3 branch grafts through the contralimb have nicely taken a triangular configuration inside the circular contralimb. And a little further down, the 3 branch grafts have nicely divided and still aneurysm is fully excluded. A 3D reconstruction image also shows the same. So why octopus endograph technique in this patient? The advantages are it's an off-label and off-the-shelf technique with a significantly less waiting time, and the device has very low profile. It's 16 to 20 French compared to the other endographs which can go up to 24 French. There are some disadvantages with this as well. The potential for compression and kinking of branch axis grafts, and we require a large axillary axis, and upward directing branches could pose challenges. So I would like to conclude by saying that EVA for complex aneurysms has significantly lower morbidity compared to surgical repair, And octopus technique using an endograft bifurcated device is an off-label and off-the-shelf strategy that can be rapidly assembled. The 3 branches can be accessed and stented through contralength, and optimal sizing is important to prevent gutter leaks. And 4th branch needs an alternative strategy, like we use a periscope stenting in this case. And catheter-guided thrombolysis is useful in decanalizing chronic aortic occlusions. Thank you.
Anybody presented earlier this case?
Sorry?
Anybody presented this case earlier in any other conference?
So we have done 5 in the last 1.5 years so far. It was actually described by Dr. Kasirajan's group, which I had quoted.
No, from your group, anybody presented this case earlier in any other conference?
The first octopus we have done was presented by Dr. George Joseph.
Yeah, you got the Iron Man.
That was the first one. This is the 3rd case we have done in our institute. We have subsequently done 2 more after this.
Thank you. That's a very good case. And
LB pseudoaneurysm, a percutaneous therapeutic possibility by Dr. Viveka Kumar, Max Hospital, Saket, Delhi. Is he there? I think. 5th one. Massive bilateral DVT, a combination of May-Turner syndrome and by Dr. Anigrahini.
He is quite young, 34 years old, presenting with a bilateral leg swelling. He is active worker ambulatory. There was no history of malignancy and there was no history of previous DVT. So just 1 week before his admission to our hospital, he was admitted to the other hospital with massive pulmonary embolism. So he was admitted in other hospital with massive pulmonary embolism and left DVT, and in this hospital he was treated with systemic RTPA infusion or thrombolysis, and the hospital implanted an IVC filter. So just 3 days after his discharge, he came to our hospital again with a recurrent, this time it's bilateral leg swelling. So in any case, this 14 days after the first symptom, he came to our hospital with a recurrent DVT. There was no major issue in his physical examination. He has no dyspnea, and then only the bilateral leg swelling, and the right sided is more than left sided. Echocardiography was normal. We couldn't find any signs of pulmonary embolism or pulmonary hypertension or the RV development. Okay, so this is the initial peripheral sonography. We use the right femoral vein access, and with the multipurpose catheter, we see a massive thrombus in the pulmonary, in the femoral vein, in the right common iliac vein and external iliac vein. And also, if you see the left-sided, the thrombus goes up into the IVC filter, and the IVC filter was sort of occluded. So next. So we advanced the catheter using just a normal thermowire into the pulmonary, the catheter into the pulmonary artery, and we confirmed that there was no appearance of the thrombus in bilateral, in the main pulmonary artery, nor the bilateral pulmonary artery or the branches. Next. So we decided, based on this massive thrombus in the right-sided vein and also the occluded IVC filter, we decided to perform the catheter-directed thrombolysis using a multi-site holes. Actually, we did it manually for the GR4 French catheter, and we deliver the alteplase continuous infusion initially with 2 mg per hour into the thrombus area, and we evaluated on 12-hourly basis. So we modified this catheter into the place where the most thrombus is. In 12-hourly basis, we continue the alteplase infusion. And after about 120 mg during this catheter-directed thrombolysis, we could see that there's a large improvement. And afterward, we can see that the complete recanalization of the right-sided veins and also the complete recanalization of the IVC filter at that time. And again, since he has bilateral DVT, so we have to observe, we did a venography for the left-sided veins. We advanced the catheter using, this time we used the help of the more stiffer hydrophilic wire and advanced the catheter into the left common iliac vein, and we observed there's a massive thrombus in the left common iliac vein and the left external iliac vein up to the mid of the femoral vein. And again, in this time, we did a similar approach for the catheter-directed thrombolysis using the multi-site holes again. And this time, we did the alteplase continuous infusion of 1 milligram per hour, and we did the 12-hourly basis evaluation. So, in each series of evaluation, we see improvement or slow recanalization of the vein. And then after a total 160 milligram of the continuous infusion of alteplase within about almost 6 days at that time, we see a complete recanalization of the left-sided vein also. And a final angiography showed apparently that there was a compression of the left common iliac vein that shows it's apparently a May-Turner syndrome in this patient. So what we decided next is was that we dilate this left common iliac vein with a balloon of 10 into 60 millimeter, and then we implanted the self-expandable stents of 14 into 80 millimeter, and we deployed the landing zone just distal of the compression, and 1 to 2 millimeter just proximal of the left common iliac vein and the IPC junction. So after the stent placement, since we saw there's a slight unsatisfactory result of the flow of the dilatation, so we perform again the post-dilatation using the similar balloon. And then after the final result of venography, we saw a very good satisfactory result of the left common iliac vein flow up into the IPC. So again, our question is, since our patient has a pattern of anatomical abnormality, so what happened with the right-sided DVT in this patient? So based on this clinical trial, we just evaluate the thrombophilic factors, and this patient was found to have a methylene tetrahydrofolate mutation, which later we found that he had an increase in homocysteine level. So this is actually an enzyme that may inhibit the homocysteine metabolism, so the enzyme is increased. And in South India, knowledge also has reported that the mutation in these genes may lead into the increase of the thrombus, systemic thrombus, or even the vein or arterial thrombus. And in men, it will increase the risk of 9.55 of ratio increased risk in thrombosis. So at the final follow-up, this patient has a very well clinical condition. He has only mild edema on both legs. The outpatient follow-up 7 days after post-discharge is a very good clinical condition with complete resolvement of the edema, and we maintain this patient in dual antiplatelet and also new oral anticoagulant. So the take-home message in this case is that a massive VTE or DVT is quite rarely occur in young person, and we have to think anatomical abnormality first, as well as the defect in thrombophilia factors that might occur as we saw in this case. And catheter-directed thrombolysis therapy for acute DVT may perform, followed by venous intervention. And we have to evaluate with a careful monitoring, because what we did here, we did a quite prolonged infusion of alteplase infusion. And some bleeding may occur, but in this patient we didn't. So we may did it persistently, and we have a very careful monitoring and a clinical decision for this patient. Thank you very
much. How long do you propose to use anticoagulants in this patient?
We did this case in February, so up to now we still give this patient in double antiplatelet or anticoagulant. So actually for the triple entry thrombus for vein stenting, there is no guideline yet. But for arterial and for coronary, we had a guideline for double antiplatelet and vein. But we observe carefully this patient, and up to now we still give new oral anticoagulant. The thing is that we had a he had these risk factors for defect in thrombophilia factor. So we have to, based on this case, I think we have to give the new oral anticoagulant, but we may have to think to decrease the antiplatelet for the patient. So probably one antiplatelet and one new oral anticoagulant, and we have to evaluate later after 6 months or 1 year, then whether we have to decrease the antiplatelet or not.
What catheter you use for perfusion? What catheter you use? CDT.
Oh, for the CDT we use the Justin right. For the initial evaluation we use the
multiple sidewalls catheter you find?
We did it manually. We did the holes manually, actually. So it's not a
the endor or multiple sidewalls? Which catheter you use? Endor or multiple sidewalls?
It's a usual GR catheter, but we did put the hole intentionally, yes.
Because
we did like 4 holes in 1.5 centimeters.
No, actually, if you take a Cook perfusion catheter, it will have almost 10 centimeters. You will have multiple sidewalls. That is the ideal catheter for CDT. So, for the wide up the popliteal vein, just put and then infuse. So that another thing, sometimes what a massive thrombus is there, that the pulverization of the thrombus, which is mild dilatations with the balloon, subsequently put, it will lead to effect more thrombolysis.
Thank you.
Next one. Dr. Viveka Kumar, LV pseudoaneurysm, a percutaneous therapeutic possibility. I think not there. LAD CTO in a left main occlusion and STEMI, acute STEMI. Is he there? Is it not there? I think. Snap stent balloon shaft during PTCA retrieved successfully percutaneously. Dr. Envo Bansal. I think not there. Acute ischemic stroke after primary PCA, intracoronary thrombolysis in young patient, double whammy, Dr. Pankaj Jariwala. I think okay. First time.